Okay, it's Mari McInerney from Croaky here at the ASMIRT conference in Darwin. We have just closed it down and I'm here speaking with Carolyn. Could you introduce yourself, please?
So my name's Carolyn Heyes. I'm a clinical radiographer who works at the Children's Hospital in Melbourne, and I'm the current president of ASMIRT.
What's your takeaway from this year's event?
Wow, we are in such good hands. Our profession is amazing. There's an amazing amount of innovation happening. There's research, and research in so many different areas. There's research to make education better, there's research to make our patients better, make their lives better, make their treatment better. There's just so much innovation and energy here. It's been wonderful.
What were any standout presentations?
I think probably the most standout ones, let me think more. Our student papers, they're researching, the student prize winner was on doing transvaginal ultrasound for endometriosis, because currently the average time for diagnosis for women is 7 years, and using transvaginal ultrasound will diagnose on the day. So it takes so long for people to actually get to there. This is going to mean that they're treated so much earlier, and given the pain that causes. Unfortunately, I didn't make it to any of the RT papers, so I can't tell you what the latest RT innovations are. I'll make an effort to do that next time. Very busy. But yeah, probably the standout was the student papers, because we're in such good hands with them. Research on occupational violence, I saw that. And then lots and lots of talks about advanced practice, which is just such a big part of what we should be doing, which again will free up our radiology and radiation oncology colleagues to move on to their high-end work when we can take up some of the lower end from them, which is advanced for us, and just means our patients will get better treatment in a more timely manner.
Now, the professional side of things is quite important at the annual conferences. Your board meets, and there's a lot around advanced practice and those sorts of issues for the profession. Takeaways?
We're currently undertaking 2 lots of scope of practice. We're redoing scope of practice documents for both radiation therapy, and we're actually doing one for diagnostic at this point in time. And we as a board are involved in the federal government scope of practice review. The next paper for that is due out later this month, and there'll be a webinar that I'll be involved in with that regarding the scope of practice. The federal government's very keen to assist us with advanced practice. They also believe that that's the best outcome for patients, so it's just a lot of work that we have to go with that. We're also now working quite closely with our unions. We're trying to get each award in each state to be a little bit more equal, so that we don't have new awards come out and then there's an exodus of medical radiation practitioners moving to another state because their conditions are so much better. We firmly believe that Australia-wide we all have the same qualifications, we all do the same work, with slight variations obviously depending on your patient population, but we think that everybody should have the same remuneration and the same conditions.
We're talking very significant differences, aren't we?
Yes, there's significant differences in pay scale. Being a Victorian, we actually get paid a higher qualification allowance for any postgrad we do, or if you get a fellowship from ASMIRT. That's not necessarily the case in other states. Sometimes it's up to your employer whether they'll give it to you, or what they give you may be very, very different. So financials are very different, conditions are very different. How many weeks leave you get. You know, I get an extra 2 weeks a year by working rostered overtime and weekend shifts. That doesn't happen in other states necessarily either. So it's just trying to get all those things even, so that people will choose to work in a state because they love the state or they come from there. They're not having to leave to go elsewhere to get the better conditions.
Another big issue that's for the health professions recently has been the government's announcement on placement payments. You're not among them?
No, we are not among them, and we're very, very disappointed that we're not. They're calling it placement poverty, and that is very much the case. We have stories of students sleeping in cars, sleeping in tents, till of course the centres find out what they're doing. I've also heard of a student whose the only accommodation they could afford was an hour and a half walk to their placement. And because they couldn't afford the transport, they were walking an hour and a half each day after doing 8 hours of placement. Sorry. So we have combined with the Nuclear Medicine Society to send a letter to the government, and we will be lobbying for our students. The professions that got those placements have a maximum of 26 weeks of placement over their degree course. Our students do a minimum of 52. So placement poverty is a very big deal for ours, and we actually lose students because they can't afford to do a 6 months or 12-week placement.
And that doesn't help. We talked before the conference about the workforce pressures that you're under at the moment.
Oh, correct. We are in a very big downswing, and don't get me wrong, it's always been cyclic, where we have graduates who don't get a job within 12 months because there's too many of them, and then we have the downswing where all of them get jobs, and we're now at the point that they graduate and we've still got the shortages. If we're losing students out of the courses due to placement poverty, then we're just going to get work, and we are still trying to recover from COVID. Unlike what the media wants to lead us to believe, we do have a shortage in all allied health professionals, not just doctors and nurses.
Is the media ignoring that?
There's a lot of times all through
refusing.
COVID, in many places through COVID, and even now when you hear about hospitals, they always talk about the doctors and nurses, but allied health professionals actually make up a third of the actual workforce. And if you don't have a radiographer to take your x-ray, you cannot be diagnosed, you cannot be treated. If you don't have a radiation therapist to treat you, then you're not going to be able to survive your cancer. So if you don't have, and I'll go for the other professions, if you don't have a physiotherapist to help you with your rehab, you're not going to recover from your surgery properly, especially if you've had orthopaedic surgery. The orthoptists, the podiatrist, all of those people are integral to the work that everybody does, but most places only tend to think about doctors and nurses. And often as a radiographer, even though I'll introduce myself, hi, I'm Carolyn, I'm your radiographer, I'm going to take your x-rays today. At the end of the session, it's not unusual to get, thank you nurse, or in my case, the parents saying to their child, do what the nurse wants you to do. We're not all nurses, and I'm not denigrating their profession in any way, shape or form, but I just wish people would understand that we are a very, very big part of healthcare.
You've had a few speakers here at this conference and previously from the UK in particular, where they seem to be or they have different development ideas for the, career paths, etc., including apprenticeships, I think, now
Yes.
in UK for trainees.
Yep.
What lessons have come out of it? What are you hoping to highlight about what's happening over there?
I personally, and I probably talk for a lot of medical radiation practitioners, would really like to see the apprenticeship model start. So the apprenticeship model means that someone is employed by a clinical centre and they do all of their study long distance, but they'll work 4 days a week paid, and they'll have a day a week for study and learning. They come out with exactly the same degree as someone who goes down the traditional university path. But it opens it for, again, it will help take away the placement poverty, because if you don't have to travel somewhere, or if you're being paid to study, you don't have to give up part-time work to do your study. And having a different option will work for some other people. When I studied, I was in a hospital within 2 weeks, and we did 2 days a week or 3 days a week. The way the system works now, the students come out in blocks, which is great for them because they have to give up work for 3 months, 6 months, 6 weeks in some cases, depending on what year level they are. But it's very hard for them to put into practice because they've been at university for anything up to 3 months, and then they've got to put everything into practice all at once, where I would learn how to do something and the next week I was doing it. So there's pros and cons for both, and depending on what your learning style is and what your financial situation is, the apprenticeship program may be far better for some people, and the traditional university path may be better for people. But to give an option would be an amazing thing. Having said that, it's not going to happen overnight. Our academics need to be happy to do so, and they're going to have to prepare the courses, because you can't take a traditional university course and then dump it onto an apprenticeship. There will have to be changes in how things are done.
Fantastic. Anything else you'd like to say before I make you melt out here?
No, just how pleased I am about the conference, and how I feel our profession is in such good hands with the older people, myself included I suppose, being mentors to those coming through, the mid-range and junior people that are super enthusiastic, and the students that are just absolutely amazing. I think we've got a really good future ahead of us once we get through this slump of not enough staff.
Fantastic. Carolyn, thank you very much.
You're welcome.